Good morning, everybody. We have to start the first session for today, the first session for the European Society of Intensive Care Medicine. And the first lecture is cirrhotic cardiomyopathy, portopulmonary hypertension, and hemodynamics in liver failure. The speaker for this lecture is Professor Jolia. She is Congress Committee and Chair-elect Consultant, Senior Lecturer, Liver Intensive Care Department, King's College Hospital in London, in UK. Welcome, Dr. Jolia.
Chair people, ladies and gentlemen, thank you. So I have to admit an absolute bias towards the liver and the circulation. I love it. But before I jump into that, I again want to thank the organizers, you as the delegates, for what is a fantastic meeting. Can you now hear me? You can now hear me. Fantastic. So let's dig in. And the first slide. So what are we going to cover here? What I would like us to think of during this presentation is that liver hemodynamics are actually quite interesting. They have a variety of syndromes that we need to consider: portopulmonary syndrome, hepatopulmonary syndrome, cirrhotic cardiomyopathy, which is not a low output state, it's actually a high output state with significant systolic and diastolic dysfunction and a poor response to exercise. We will cover briefly liver congestion and hypoxic hepatitis. I am not going to talk about disease-specific issues, such as the cardiomyopathies of hemochromatosis or alcohol, nor Alagille's, but be aware that pediatric liver disease and adolescent liver disease is now growing to adulthood. So peripheral pulmonary stenosis and all of those issues will now be arriving in our adult intensive care units. Hereditary hemorrhagic telangiectasia, a particular problem, and increasingly short telomere syndrome. So this is a cohort of people who present in their late teens, mid-20s. They might present with aplastic anemia, pulmonary fibrosis, or liver cirrhosis. And increasingly, we will be offering organ transplant and bone marrow transplant for that cohort. And it's a growing group that we're recognizing and managing differently. And cholestatic lung disease. I'm going to talk briefly about the problems potentially of albumin and terlipressin, less so about the cardiopulmonary disease that impacts on liver function. So the basic cardiovascular system is quite simple. It's a high output state. It's an increased circulating blood volume, most of which sits below the diaphragm in the splanchnic bed. So big volume, wrong place. We are learning certainly in our critical care management to use early vasopressors to move that circulation, and that is particularly pertinent in liver disease, where you have that venous volume that you can push into the central circulation. Norepinephrine is our first drug of choice. Ascites is interesting, and I'll show you a bit of data about that. But think about it, if you've got a raised intra-abdominal pressure with your liver disease, you have impaired venous return. And sometimes a small volume paracentesis has a big impact. Hypoxic hepatitis. We see it not infrequently in our general ITU patients. It is usually in the setting of cardiac or respiratory failure, an increase in the transaminitis, and exclusion of other causes of cell injury. Nearly everyone to get hypoxic hepatitis must have a degree of right heart dysfunction and liver congestion. That is almost a prerequisite. If you see hypoxic hepatitis, examine the right ventricle. The only other thing that you must consider is portal venous inflow. And you see here the importance of hypoxic hepatitis and cardiogenic shock in terms of outcome. Importantly, primary outcomes, once you've got hypoxic hepatitis, considerably worse. You really need to look at it. The important outcome factor is an elevated lactate, which doesn't come down rapidly. That drives you towards poor outcome. The liver, you need to support. You support the liver by supporting the heart and the respiratory system. The liver is a bystander. So focus on the heart and managing the heart. And sometimes you get it wrong. This is a case who was referred to me as acute liver failure on the unit I work in. He was a young man in his 20s. He had profound coagulopathy, an AST of 10,000, an elevated bilirubin, lactate, and ammonia. But in fact, he had a viral cardiomyopathy with profound hypoxic hepatitis. He is managed best by VA ECMO, and the heart and the liver get better. He does not need a liver transplant. Similarly, CT and ultrasound, really useful. This is someone with significant aortic valve disease and mitral regurgitation. You see here the size of the hepatic veins, grossly congested, almost no outflow. We also need to consider increasingly the role of severe respiratory failure and vasoplegia and the use of vasoconstrictors on the risk to the biliary system. So if you are hypotensive and hypoxic, remember that your biliary tree is supplied almost entirely by your hepatic artery. And increasingly now, we are beginning to see secondary sclerosing cholangitis in our profoundly unwell patients. It became very prevalent during COVID, and increasingly we recognize it now. So when you see cholestasis of sepsis, always think if it's persistent, at some point you need an MRCP. A cohort of these patients you will have given, or they will have acquired, another disease. This is looking at ascites. So, hyperdynamic circulation. With or without in the here, one sees someone with Budd-Chiari. So you have an obstructed hepatic venous system. This is what you see on the liver, aortoporto shunting. And the blood flow in the portal vein is retrograde, so not antegrade. They have a lot of ascites. They have impaired venous return. You can see the IVC there significantly compressed by the liver and the caudate lobe. And this is some really old data that we did at King's, looking with a PICO at pre and post ascitic drainage, taking off 2 liters of ascites, small volume, large pressure drop. You can see there is little change in mean arterial pressure, but there is an improvement in old money, intrathoracic blood volume. There is an improvement in cardiac index, and indeed in stroke volume and the intra-abdominal pressure with just a small volume ascitic drainage drops significantly. So improved venous return. That's Budd-Chiari. You see exactly the same thing with chronic liver disease, with this improvement in cardiac output, an improvement in central blood volume, and an improvement in stroke volume index. So always think about that, slightly lateral thought about how you can improve venous return. Moving on to the respiratory system in liver disease, you have a hyperammonemic patient that drives hyperventilation. You have central activation of progesterone and estradiol receptors. You have hepatopulmonary or portopulmonary syndrome that we've talked about, hepatic hydrothorax, and diaphragms which sit very high and contribute to tachypnea. So many of these patients have baseline tachypnea and a respiratory alkalosis. And of course, a respiratory alkalosis affects your NH4, NH3 equilibrium, and you have increased risk of encephalopathy. This is seen also here, but particularly I would like you to focus perhaps on hepatopulmonary syndrome, cyanosis and clubbing, worse when you sit them up, they resaturate when you lie them down, diagnosed by bubble echocardiography. Also think importantly about hydrothoraces. As you see here, this can get bacterial peritonitis, just like ascites. You can sometimes drain it by going through the ascites because of all the holes in the diaphragm. Sometimes you have to drain it directly. If you put an intercostal chest drain in, it might drain 8 liters a day quite happily. So you've got to manage that hemodynamics. So is ARDS an issue in liver disease? And I have always found this fascinating, that the vast majority of the patients that I look after with chronic liver disease and acute liver failure do not get an acute lung injury or ARDS for the first week. And there is something about your liver which appears to be protective to your lungs. No idea what it is. But you do get ARDS later in the disease course as their livers start to get better. However, importantly, it is not that prognostically significant, and we will often transplant someone with ARDS, and as the liver gets better, you can improve the lungs. Hydrothoraces, as I've said, 17% on the left versus the right. Increased complications. Remember that you do have varices in your intercostal area, and going through a varix with an intercostal chest tube is a deeply unpleasant experience. It can be infected, and it can frequently become an empyema. You can put indwelling pleural catheters in and manage them that way and move them to transplantation. And really, the management of this is transplantation. I want to move on to albumin, because albumin is something we all give in liver disease. I have to put my hand up. I don't. I'm an anti-albumin person. I will occasionally give it, but not that often. So this is a study of albumin in hospitalized patients with cirrhosis, the entire study by Alistair O'Brien. Everyone got either albumin to get to 30 grams or standard of care. And what was fascinating in this was that there was no difference in terms of composite endpoint, no mortality benefit of giving people albumin, and they were a moderately sick group. But what they did have was a significant incidence of complications, all of which were respiratory in nature. And you see that here. So significant increase in effusions, pulmonary edema, and adverse events. So you start to have to worry that we are not very good at managing volume in patients with liver disease if we're giving regular albumin. This was also seen by the work of Florence Fong treating hepatorenal failure, albumin and terlipressin. Great study, hit the primary endpoints for improving renal function without question. It works, but it works with a significant complication risk in the albumin and terlipressin group of pulmonary complications and respiratory failure. And so following that, following that study, the European Drug Administration and the UK equivalent gave guidance that you don't give terlipressin and albumin to ACLF grade 3 or with a high MELD score when you're moving towards transplant because of the risk of respiratory complications. Do we do it? Yes, everyone still does it. It's quite interesting. We avoid guidance. So, hepatopulmonary syndrome. Big AV shunts within your pulmonary vasculature. This is the definition. You've got to have a positive bubble echo or a cerebral uptake of greater than 6%. It's not only in cirrhotics, it's also in people with portal hypertension. So nodular regenerative hyperplasia, or in patients with just portal vein thrombosis, portal hypertension, you can get hepatopulmonary syndrome. So echocardiography regularly plus agitated saline and you can check out what's going on. And transplant, again, is the treatment of choice. This is what you see on CT, really nice, big, chunky pulmonary shunting. This really nice study, quite old now, but showing an increase in hepatic venous endothelin-1 across those with evidence of hepatopulmonary syndrome. And again, if you look at CT evidence, clear correlation between the diameter of pulmonary vessels and your hypoxemia. Beautiful review, if anyone wants to read it, in terms of the etiology of hepatopulmonary syndrome. But at the moment, we have little in the way of treatment. There seems to be a really clear correlation with your degree of hyperdynamic status. You see this in terms of the controls versus those with hepatopulmonary syndrome. This is non-invasive assessment of cardiac index using echocardiography. And again, increasing as your functional class worsens, and also in terms of the severity of your hepatopulmonary syndrome. And similar AA gradient cardiac index is seen very clearly. Now that's important because when you've got someone who's really hypoxic, one of the ways of treating it in liver disease is to drop their cardiac index as best you can. And we will often beta block these patients or undertake other modalities to try and decrease their cardiac index and improve their oxygenation. So what are the treatment options? Well, not many. None have thus far proven effective. You always need to think if someone isn't suitable for transplant, chronic, or even suitable for transplant, chronic oxygen therapy at home, embolization of AV shunts. And it's worth saying for these patients, not relevant for ITU particularly, but if you exercise them, they desaturate profoundly. So if you do a 6-minute walk test, we do that when we're assessing people on the ward, they go down into the 60s and 70% saturations. They're a bit short of breath, but they're not that symptomatic. However, liver transplantation does reverse it, but it takes a long time. It doesn't reverse quickly, and it depends on good graft function and resolution of the portal hypertension. So you can get into a real pickle post-transplant. You need to manage them sometimes in the Trendelenburg position, flat. You extubate them only about 10, 20 degrees head up. Inhaled epoprostenol sometimes works. No trials. Inhaled nitric oxide sometimes works. No trials. We will sometimes use intravenous methylene blue, confuse the receptors. That sometimes works. Rarely embolization of shunts, and sometimes you need ECMO. We will always try and beta block people, and we will decide whether to move towards ECMO based on whether the liver graft is beginning to get unhappy. So let's now move to portopulmonary syndrome. Again, portal hypertension, it doesn't need to be cirrhosis, and associated high pulmonary artery pressures. It's a reason to put in a PA catheter. It's seen in about 10% of cirrhotics, and you need to always, again, think about screening, echocardiography, and right ventricular dysfunction and volume overload. Pro-BNP is a good marker, and we use it as a regular screen. The pathogenesis is very similar to standard pulmonary hypertension. Definition is a mean pulmonary artery pressure of greater than 25 and a pulmonary vascular resistance index of greater than 250. And you can have both pre and post capillary, and they are both equally common. And again, that's a reason to put in a PA catheter once you've got evidence of elevated right-sided pressures on echo. You need to define whether this is pre or post-capillary, or whether it's a mixture, because the management is different. You calculate your transpulmonary gradient. It's really good old-fashioned physiology. Is it practically important? Yes, it is. This is someone who presented with variceal hemorrhage. The ward went forward for a tip shunt. Very sensible. However, the patient had pulmonary hypertension that they hadn't diagnosed, and hence the pulmonary pressures were high, the right-sided pressures were high, the TIPS was useless because the pressure in the portal vein remained elevated. What's your prognosis? And it's important to recognize that if you haven't got cirrhosis, you should not be considering transplantation, and you need to manage them conservatively with medical management. If, however, you're a Child-Pugh B or C, then move forward to transplantation. This data, really nice. Diagnostic criteria, as you see there, the mild, not a problem going forward. The moderate, you're beginning to move into difficult territory. The severe, definitely difficult territory in terms of transplantation. And really nice data now showing the efficacy of medical therapy, the Portico study, looking at mesantanan in terms of improvement. Now, the one thing to say is Child-Pugh C wasn't included in this study because they went forward for transplantation. But we should be medically managing these patients. We will often send them home also on epoprostenol and other pulmonary vasodilators, be it bosantin or sildenafil. So in the patient with portal hypertension and pulmonary hypertension, you need to determine whether it's pre or post-capillary. You need to look at the hyperdynamic state and the cardiac index. I would disagree with these authors and say the volume overloaded group are all profoundly hyperdynamic, in my personal experience. The pulmonary hypertension group, the arterial ones, they eventually show a decrease in cardiac index, and at that point you really shouldn't be transplanting them. But you treat them, you stabilize them, and then you can proceed to transplantation. The severe pulmonary venous hypertension, you have to take the volume off. I'm aware of time, Chairman, I apologize. And you need to sometimes use vasopressors to achieve that. And without question, pulmonary hypertension worsens your outcome post-transplant, both in terms of graft survival and in terms of individual patient survival. So be cautious when you're managing these patients. Cirrhotic cardiomyopathy is endemic. We should be doing regular echoes. We should be using the definition criteria. We should be looking at QTc interval. Transplantation cures the QT changes. It does not necessarily change the diastolic and the systolic dysfunction. And what's increasingly interesting is that this seems to have an impact on the cardiovascular risk post-transplant. So this is a group that need their cardiac assessments post-transplant being really beautiful long-term. So in conclusion, respiratory physiology is fascinating to me in liver disease, but I'm an enthusiast. It allows us to really address physiology at the bedside. Transplantation is often the appropriate intervention, but we need to manage and we need to modulate. In terms of transplantation in people with other causes, we need to do CT angiography, we need to do exercise tests, we need to look at drug-eluting stents and time to transplantation. So, Chairman, ladies and gentlemen, thank you for your attention.
Thank you so much, Julia, for this excellent talk and overview about the portopulmonary hypertension. Just one point to say is that we have all the questions at the end of the session, so please stay in the room until the end of the session, and we'll have all the interesting questions with all our speakers. So now it's my pleasure to introduce the next speaker. I don't know if he really needs an introduction, as he's the Congress Chair and the Director of Abu Dhabi Anesthesia Club, Senior Consultant Anesthesiologist in Sheikh Khalifa Medical City here in Abu Dhabi. So it's my pleasure to introduce Dr. Yasser Zaghloul to talk about brain-lung protective strategy, airway management and ventilation in acute brain injury patients. Dr. Yasser, thank you.
Good morning, everybody. Every day we have a patient with acute brain injury, and we need to resuscitate him either to maintain the airway or to do the proper ventilation. So what we can do with a patient like that? So we will discuss the physiologically difficult airway. We'll focus in the patient with acute brain injury, the concept of the neuroprotective airway, and then to summarize the ventilation. We have the physiologically difficult airway. Actually, this term came from the emergency doctors, not from ICU, not from anesthesiology. Since about 12, 13 years, they are facing the patient like that in ER. So it is this term taken by anesthesia and the ICU after that and do more extension. So we will focus in the patient with high intracranial pressure. Types of acute brain injury, it may be traumatic, either isolated traumatic brain injury or other associated injuries, stroke, hemorrhagic or thrombotic, subarachnoid hemorrhage, infection. Some patient after surgery or craniotomy, he deteriorate and you need to intubate him. The issue that the injured disease, just injured operated brain is very liable for secondary brain injury. So our main job, either in ER or 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 ICU, to prevent or to minimize the effect of secondary brain injury. So what is these factors? On top, hypotension, hypoxemia, hyperoxia, hypo and hypercarbia. So that's why we are talking in the ventilation at the same time. Hypovolemia, hyperthermia, acidosis, anemia, hyponatremia, high ICB. If the patient has coagulopathy, it will expand the intercerebral hematoma, hyperglycemia, hyperemia, and seizures. The point that we mentioned hypotension and hypovolemia. Hypotension can occur in patients in acute brain injury without hypovolemia, like patient with the neurogenic stunned myocardium. This according to the severity of the brain injury. The term neuroprotective by Professor John Doyle from Cleveland Clinic, Ohio. He is with us here, and he wrote these articles in the last months to explain our strategy how to protect the brain. So, patient coming with brain injury, you need to intubate. What is your indications? Glasgow Coma Scale more than 8. Patient can protect his airway, high ICB, brain herniation, severe agitation, and non-neurological comorbidities like the patient with severe chest trauma and multiple orthopedic injury, and he needs to be taken for operating room for surgery. So what is the challenges in these patients? First, patient coming with full stomach and high risk of the vomiting. Urgency, you don't have enough equipment or persons with good experience. Patient is hypotensive, and if you give any medication, he may collapse and even arrest. Patient has C-spine. It is difficult to move the head and difficult to intubate. Patient respiratory has maybe pneumothorax, hemothorax, and you need to pre-oxygenate. Whatever you pre-oxygenate, the patient will not benefit from the pre-oxygenation. And you have to, a patient may came already with hypercarbia and hypoxia. During the process of intubation, this may worsen more and aggravate the brain injury. And the last, abnormal anatomy. If the patient has maxillofacial trauma, again, this may cause difficult intubation. So you have a lot of challenges just to put the tube. You have to deal with all this to protect the brain. So we have many preparations to prepare the patient for the intubations, and all of us using the rapid sequence induction. But we have the concept of what is named delayed sequence induction as well. In agitated patient and difficult to pre-oxygenate, you need to give some ketamine and the patient head up to can pre-oxygenate, then intubate. Again, the term of delayed sequence intubation came from ER. It is not from anesthesia, it is not from ICU. So we'll go first for pre-treatment. You have the patient is hypotension, hypovolemic, and the patient may have high ICP. Can you do something before the process of intubation? Why you are discussing that? Because the patient coming with cardiovascular collapse, he may be hypovolemic. The patient may have cardiac dysfunctions. The effect of induction agents and the effect of the neuromuscular blockers and the ventilation. So you should be ready for all these changes before putting the tubes. They found that patient coming with moderate to severe TPI and has hypotension, two-fold increase in the mortality. That's why we are very careful to maintain the blood pressure during the process of intubation. The other poor factors, as you see, hypotension, hypoxemia, high ICP, and if the patient needs mechanical ventilation. All this will worsen the outcome of patient with acute brain injury, whatever, traumatic or non-traumatic. So can I give vasopressors? Can I give volume? Can I give sodium bicarb if the patient is acidotic? And can I give hyperosmolar agent before the intubation? We will see. In this study, they give the vasopressors before intubation. What they found there, the hypotension and the change in systolic blood pressure, new use of vasopressors, cardiac arrest, 30 days mortality in higher in the vasopressor group. So to give vasopressor or no, this is a big question. Why is this result? They found that the vasopressor given patient with old age with minimal cardiovascular reserve and given the patient with more Apache score. So it is very bad patient from the start. That's why the outcome is not good. The cardiac arrest is higher and the mortality is higher. Can I give volume? Again, they tried to give volume to the hypovolemic patient before the intubation. They found that there is no difference between the two groups, whatever you give fluids or no. But for myself, if the patient coming with hemorrhagic shock, I have to give something, either crystalloids, albumin, or blood before, partial resuscitation before giving the anesthetic medication. Now, very interesting study is running, prevention studies, to give vasopressors before or during the tracheal intubation, and 3 or 4 days before they completed 50% of the patient enrolled in the study and expected to finish in 2008 or 2007, 27, sorry, I'm not sure, but still only 50% of the patient included in this study. As I explained earlier, hypotension, you should differentiate the causes of hypotension in patients with acute brain injury. It is due to the hypovolemia, or maybe the patient has spinal shock from cervical spine injury, or severe neurogenic stendomyocardia. And this is because of the catecholamine surge, and severe inflammation and vascular dysfunctions from the severity of the trauma itself. And in these patients, they have ECG changes, and if you did echo, ejection fraction on most of the patient is around 40% or even less. And in this case, you can give dobutamine or milrinone, and fortunately, the patient can recover within few days from the time of injury. Actually, in patients with acute brain injury here, hypertension is common. It can occur from 35 to 40% of the patient. So you have to be ready for both hypotension, hypertension, and tachycardia as well on the same time. So patient, again, any signs of herniation or increased intracranial pressure, you can give mannitol or hypertonic saline before intubation. Again, the neuroprotective strategies, what we can do, pre-oxygenation. So what is the best way for pre-oxygenation? Here, if you give the patient a non-invasive ventilation and just the oxygen mask, the incidence of hypoxia with simple oxygen mask is 18%, non-invasive ventilation by bag mask is 9%. So from this, initially, we have the bag mask is better than just normal breathing. This is the first one. Second one, we have the high flow nasal oxygen cannula, and you have a lot of options from that. If there is a collapse of some alveoli, it will inflate this alveoli. And if some sort of bronchoconstriction, you will have bronchodilation. Decrease the nasal resistance, patient may have some blood or secretions in the nose, it will reduce the resistance and increase the secretion clearance. At the same time, you will improve oxygenation and you will reduce the hypercarbia, so you minimize the secondary brain injury. Here's a very interesting study. They compare all the methods used for pre-oxygenation, starting from simple face mask and asking the patient to take deep breathing until the high-frequency oxygen with the pressure support in the same time. The lowest saturations occur with the high-frequency nasal oxygen in head-up position, and lowest saturation is 88%, so it is acceptable in this case. If the patient high-frequency oxygen, only 72%. At the same time, you have a prolonged safe apnea time. From time of stopping oxygenation until you are putting the tube, you have a gap here. So the desaturation during this time is much less with the high-frequency nasal oxygen. And again, another proof for that, most effective high-flow nasal oxygen in patient in head-up positions. Okay? And this is used immediately in OR before craniotomy. Patient not intubated in ICU, not intubated in ER, and they came for the OR for intubation. They used the transnasal humidified oxygen, and they found that better brain oxygenation, and in the same time, they improve the neurological functions in these patients. So it has a role in OR as well. So to summarize, which patient and what is the oxygenation? If it is just mild hypoxemia, simple oxygen mask or bag mask ventilation is okay. Mild to moderate hypoxemia, you should use the bag mask ventilation. Moderate to severe hypoxemia, you need to add non-invasive ventilation or CPAP as well. And severe hypoxemia, you should use high-flow nasal oxygen. And all time, when you stop the pre-oxygenation, you should keep nasal cannula 15 liters per minute during the process of intubation. This is apneic oxygenation. You may do your best. You are doing everything, but still the patient is saturated. You have some reason. In obese patient, up to 13% may develop hypoxemia. And also, you should consider the patient variabilities. The patient may have already small functional residual capacity. Obese patient, as we mentioned, patient with respiratory distress syndrome, patient with lung fibrosis, and the patient increased oxygen consumption. Maybe you didn't do the apneic oxygenation well. All these factors may not optimize the pre-oxygenation. Okay, you pre-oxygenated the patient already, and you need to give the muscle relaxant and the sedation. Here, cardiovascular instability occurs in 43% of critically ill patients during the intubation. Severe hypoxemia, 9%, cardiac arrest in 3%. So you need to select the drug well. You have either benzodiazepine, propofol, or etomidate, or ketamine. In this study, they found ketamine is the best, but it is all critically ill patients, not specifically to the traumatic brain injury. So they need to specify the dose. Usually, you give the full dose 2 milligram per kg. You may start 0.5, 1 milligram according to the patient clinical status. When etomidate is used, this meta-analysis of 11 randomized controlled studies, they found that the mortality increased with etomidate. So now, initially, ketamine is better than etomidate in critically ill patient, whatever, with brain injury or without brain injury. We will come now to the patient with traumatic brain injury. They found no significant difference between etomidate and ketamine. So a little bit still confusing. From our side, I think ketamine is still a safe drug, can be used. Another trial is running now, these SPIKE trials, brain injury and ketamine, and they included already 70 patients and expected to complete in 27, and we will wait these results, the effect in ketamine in the brain injury. Which muscle relaxant, it is not too much studied to compare the muscle relaxant. This is a little bit old, 9 years ago. They found succinylcholine higher mortality than rocronium, 44 and versus 23%. And this may be, I can't explain it well, the increase in ICP with the fasciculation during succinylcholine injection. Here, pre-hospital study. They found that most of the outcomes, succinyl and rocronium, is the same. The only difference is that shorter time for the intubation, 1 second and 1 second. So the difference 30 seconds. But this difference in 30 seconds is significant for the patient who has brain injury, either hypoxemia or hypercarbia. So I don't know, maybe to use succinylcholine or rocronium, but most common now, rocronium is considered safe in the patient. Now, to perform the intubation, regarding the cricoid pressure, should we use it or no? There is a lot of controversy about that, to use or not to use. Safety, it is not proved safe 100%. Efficient, it is not efficient 100%. And what is the future? Most of us now use the video laryngoscopy. Video laryngoscopy with cricoid pressure, you can't see well. So you may ask the assistant to remove the cricoid pressure. And global variations. Some hospital or centers or countries recommend to use it. Other countries is not using it. So what we can do, again with Professor John Doyle, is the evidence is very little, but it still can be used in some patients. Okay, it is up to you. It is not mandatory to use the cricoid pressure. In patient coming with cervical spine injury, you should use video laryngoscopy better, and semi-rigid or rigid cervical collar, you should remove the interior part during the intubation, and the fiber optic intubation has a role in this group of patients, and everybody should be trained and plan well if the patient has cervical spine injury. Again, there is other evidence that you should remove the interior portion of the cervical collar before intubation to keep the intubation easy for you. Cricoid pressure, here you can see 4 persons are doing the intubation. 1 person fixing the head for manual inline stabilization. And 1 person is going to intubate, 1 person is giving the medication, and 1 person is going to do the cricoid pressure. Actually, it is too much. You can need 2 persons only. But the other person should be careful during applying the manual inline. Here, if you apply it on the jaw, it is minimizing the movement and difficult to introduce the laryngoscopy. So it should be on the ear with the occipital, away from the jaw. Which laryngoscopy you have to use? Here we compare the direct laryngoscopy with video laryngoscopy. Video laryngoscopy is better in the first pass and 85% intubated from the first attempt. Video laryngoscopy of fiber optic, again, video laryngoscopy is a little bit better than fiber optic, but still fiber optic has a role in patients with cervical spine injury. This one of our patients, 4 from height, severe TBI, fractures in the nose and maxillary fractures, and he has stable fracture C6 and C7, and fortunately this patient intubated with the video laryngoscopy without problem. A lot of talk about the comparison of video laryngoscopy and normal laryngoscopy. All of them recommend video laryngoscopy either in ER or critically ill patients should be the first option. And more recently in the European journal, this will be published the next month, the video laryngoscopy should be the standard and the routine in all intubation, and everybody should be trained for that. So should become the standard care of tracheal intubation. Now you put the tube and you have to confirm the tube in position. Of course, you have sustained capnography waveform, and if it is attenuated or start low, then increase with the time. And after that, you may have very attenuated.
The big question now, the last one here is almost the same last one here. This inside the trachea and this outside the trachea. How to can explain that? Do you have any explanation? Here, the patient, the green one, the patient may be post-cardiac arrest or severely hypotensive, very low cardiac output. The lower one may be bag mask ventilation and still a lot of CO2 inside the stomach, or the patient drink carbonated drinks before coming for the hospital, and you may this one. So you should correlate with the clinical status of the patient. The best to see the tube under vision is going between the cord. This is 100%. Everybody can see, and especially if you're using the video laryngoscopy. The last point is for the ventilation. Any patient with severe traumatic brain injury may develop adult respiratory distress syndrome, severe inflammation, cytokines release, disruption of the blood-brain barrier, and causing endothelial injury of the lung. At the same time, injury of the lung may cause hypoxemia, decreased oxygen delivery, and hypoxic brain injury. So you should break this vicious circle to improve the patient outcome. So lung-brain protective ventilation, just I did some modification. The lowest possible of IO2 to maintain PO2 more than 80. CO2 within normal, except the patient have embedded herniation and you need to hyperventilate. Driving pressure 15 and tidal volume may be 6 to 8. Low plateau pressure, P5 to 10, and the proper sedation and the proper use of the neuromuscular position. So the questions here, in patient with traumatic brain injury, can we use PEEP? Yes or no? You can assess the patient, all right? Here, if the patient already has high normal ICP or high ICP, if it is normal and no signs of respiratory distress syndrome, you can ventilate as usual. If the patient has adult respiratory distress syndrome, you have to follow the protective ventilation and you may need to use higher level of PEEP. If the patient has no ARDS but PEEP insensitive and high ICP, that means you are increasing PEEP but no effect on the ICP. This means PEEP insensitive. So ventilate as usual. So we will come to the big problem, high ICP and ARDS in the same time. So no recommendation. But I think the control of ICP is much easier than treatment of adult respiratory distress syndrome. It will take few days to improve. But ICP, you can reduce it either with CSF drainage or with hyperosmolar therapy by decompressive craniectomy. You have many options. But respiratory distress syndrome, you have to ventilate until improving the condition of the lung. So for the VentiBrain multicenter observational study, the hazard increase with increasing the plateau pressure, with driving pressures, the best PEEP between 5 to 10, and the best respiratory rate between 10 to 18, and the best FiO2 around 40%. This is again another proof for the protective ventilation. You have to avoid hyperoxia. If the patient has high PO2, this will worsen the neurological outcome and will increase the mortality as well. That's why we focused in the PO2 to be within normal. Maybe 110 maximum or 120 is okay. When automated ventilation is used, it is better than the routine conventional ventilation. And in conclusion, you have to pre-oxygenate well, sedate the patient, intubate, confirm, and the post-intubation care. And thank you very much for your attention.
Thank you so much, Dr. Yasser Zarloul, for this nice overview about the airway management in this specific population of ICU patients. And now it's my pleasure to introduce Professor Denise Battaglini. She's a consultant in intensive care and anesthesiology in Polyclinic San Martino. Hospital and an assistant professor of the University of Genoa. And Professor Denise Battaglini will talk today about identifying when non-invasive respiratory support becomes a foe in severe hypoxemia. Thank you.
There is nothing here. Okay, let's start. Thank you so much for the invitation again. These are my conflict of interest. So now, why do we provide non-invasive respiratory support? For a bridge to recovery, for a bridge to intubation, and unfortunately, sometimes for a bridge to nothing. So we start from the mechanism of failure. Why do sometimes the high flow nasal cannula, the NIV, or the CPAP fails? Because we could have problems in the respiratory mechanics and the ventilation, we can have problems in the perfusion or in the diffusion mechanism. Then, while the disease progresses, we can have an excessive respiratory effort and a patient exhaustion. And this is what we call patient self-inflicted lung injury. But does self-inflicted lung injury exist? Yes, we have some proofs that it exists. And as you can see here, here is a patient with a spontaneous breathing at ZIP or CPAP. And here you can see how hard the swings of the respiratory effort. And then when you apply any respiratory effort to this patient, the patient stop and decrease the negative pressure and the expiratory effort. This is a study we did in the timing of COVID-19 with our group. We included critically ill COVID patients who failed the helmet CPAP and required intubation. And we saw if early intubation, meaning less than 2 days of CPAP versus late intubation, more than 2 days of CPAP, were associated with improvement in the outcome. So we did also a quantitative CT analysis at 2 levels of PEEP, one 8 and the other 16. So what we found was that more non-aerated and poorly aerated lung tissue in late versus early intubation group, a worse in oxygenation and respiratory system compliance at intubation and ICU admission in the late group again, and similar lung recruitment with a higher PEEP in the 2 groups. So there is a timing for failure, and the timing can be seen as the patient worsens. You can start when the patient still is with a quite good respiratory mechanics, quite good PF ratio with an NIV. Then there is a severity window which is very, very small, in which the NIV may help, but maybe is not, may also worsen the patient status. And then when the patient go downward, the NIV can be insufficient or risky. And then the same for endotracheal intubation. At the beginning could be dangerous because you expose the patient to excessive risk, but then it is needed when the patient worsens too much. So the message here is that the delay in endotracheal intubation is the main hypothesis to explain the mortality excess of hypoxemic patients who fail the NIV. the NIV failure and the cause of acute respiratory distress or acute respiratory failure are really important. As you can see here, patients who failed more were those with certain specific etiologies of respiratory failure, like patients with pulmonary RDS or CAP or nosocomial pneumonia. While those, for example, with pulmonary edema failed less the NIV. So this window is very strict, and as you can see here, after 1 hour, you can easily detect already the failure by using the PF ratio. When you see that the PF ratio is starting decreasing after 1 hour of NIV, let's think about what doing after that. So no improvement, consider intubation early. When do I have to intubate? Then there is a small window, as I told you. So if you intubate too early, there is a higher risk of death. If you intubate too late, there is an increased risk of death as well. So what to do? The first thing to do is the clinical assessment. It is also the best thing we can do at the bedside. Then, if we are practiced, we can make an esophageal pressure monitoring, we can make a diaphragm ultrasound, electrical activity of the diaphragm, or electrical impedance-derived methods. How to assess the inspiratory effort? So this is an example. This is what we can do with an esophageal catheter. We put the esophageal catheter and we have a surrogate of the pleural pressure. So here we can easily measure the transpulmonary pressure. We can partition the mechanics. So it is a quite easy way to assess the patient effort. Even during spontaneous breathing, you can use the esophageal catheter. Here there is an occlusion to see if the catheter is well positioned. You make an occlusion during the patient effort, and when the airway pressure and the esophageal pressure are quite similar without so many difference, the catheter is well positioned. We can also measure the work of breathing. It seems not so simple if you look at this, but the work of breathing reflects the muscular pressure related to the volume, to the certain volume. And the normal value is around 0.35 to 0.4 joule per minute. But it has some limitation. The work of breathing does not account for the duration of the respiratory effort, and the work of breathing does not reflect the true energy expenditure of the respiratory muscle in case of isometric effort. Then we can measure this, which is quite even more difficult. Sometimes we can measure the esophageal pressure time product, and in this case we account also for the time. As you can see here, you account for the time of the effort, so is maybe better than the one before. And you account for the swings in the esophageal pressure, you account for the transpulmonary pressure, and you can account also for the area under curve, looking at the resistance and the inspiratory pressure time product. How do I really estimate this at the bedside? Maybe just looking at the swings and putting an esophageal catheter is easier for us at the bedside. But of course, you cannot put in all patients on NIV in the ICU. So maybe those who may require this monitoring are those that risk more intubation. There is another method. This method is the nasal pressure swings during the tidal breathing. This is a quite good method, and it is very reliable because this method correlates well with the swings in the esophageal pressure, both using the high flow nasal cannula and the NIV. So this method is easiest at the bedside, and you can think about using it. And then the gas exchange and tidal volume. So, okay, we look at the PF ratio. The PF ratio maybe is too simplistic because if your patient has a shunt, for example, of 20, when you put a VO2 of 0.2, here you see that the PF ratio decreases, and then you rise the FVO2 and the PF ratio increases. And the same, but with a different pattern, is with a shunt of 60%. You see, when you increase the FVO2, the PF ratio tends to decrease. This because this appear also with the changes in the cardiac output. So the Berlin definition, okay, we need at least PEEP or CPAP of 5. Then the new global definition included also the patient with high flow nasal cannula or patient with NIV. But pay attention because the PF ratio can be misleading, so can be influenced by hemodynamic, by shunt, and by other things. Nonetheless, looking at this study, this is a secondary analysis of the lung safe in which were compared the patient according to the severity using the PF ratio below 150 and above 150. You see that in the patient they were more severe, so the PF ratio was below 150. Invasive mechanical ventilation had a higher survival probability than using a non-invasive technique. In those less severe, this effect was not seen. And another important parameter is the tidal volume. Tidal volume, but we have a patient who is not intubated, so it is difficult to measure, but if you can monitor it, you can see that, for example, here in this study, when the PF ratio is above 200, the effect of the tidal volume between the NIV success and NIV failure is not so important, but in those severe patients with a PF ratio less than 200, the higher tidal volume, the higher failure, the higher risk of failure, sorry. So here you see the trend over days when the tidal volume is above 9.5 milliliter per kilo of predicted body weight, you see that the risk of failure is even higher. And then we can use the clinical scores. Using the clinical scores, you can predict the failure. One clinical score can be the ROX index. It has been designed for the high flow nasal cannula, and this score is the ratio between SpO2, FeO2, and the respiratory rate. So in this nice study from Roca in 2016, you can see that the ROX index above 5 was significantly associated with an increased cumulative probability of being free of mechanical ventilation. And the same, also using the ROX index, you see that the survival proportion is changing at 2 and 6 hours of high flow nasal cannula. You see that those with a higher ROX index has an increased probability of being free of mechanical ventilation. Sorry. And also, the relative risk of death according to the time of intubation in this patient who failed high flow nasal cannula is driven by higher scores. The ROX index in the real world, for example, during the COVID pandemic, yes, we used, and this is a sample of more than 1,000 patients, among a cohort of COVID-19 subjects who were ultimately intubated. A higher ROX score at the time of intubation was positively associated with survival. And then you can use specific scores for NIV. For example, the HACOR score. This is the validation cohort of the HACOR score. And this score includes the heart rate, the pH, the Glasgow Coma Scale, the PF ratio, and the respiratory rate. This is a quite good score, as you can see, increasing. It can be used 1 hour or 24 hours. You can use it at different timings, and it is highly predictive. Thus, the use of the nasal probe, as I showed you before, is also even very specific and very sensitive for detecting those patients at risk of failure, but is even also associated with the ROX score. And there is another score, which is the PROX, which is the ratio between the SpO2, VO2, respiratory rate, and delta P nose. So I go to the take-home messages. The first message is that the clinical evaluation came first, always. Then pay attention to any sign of deterioration. Talk to the patient. Communication is important. Ask to the patient how he or she feels. And then consider the lack of improvement as a near failure, and look at the inspiratory effort and respiratory rate. Look also at the volume if possible, but look mainly also at the PaO2, PaCO2, and pH to choose your next effort. Thank you.
Thank you so much, Dr. Dennis. Our next speaker is Professor Jamaico, and he is the General Secretary of the European Society for Intensive Care Medicine and the Head of Department Emergency in Foundry Zone IRCCS. Also, he is a full professor of anesthesiology, intensive care, Department of Pathophysiology and Transplantation, Milan University, Italy. Welcome, Professor Jamaico.
So, good morning. We're talking about ECMO. Huh? These are my conflicts of interest. So, these are the general guidelines of the Extracorporeal Life Support Organization regarding the contraindications to ECMO support. And as you can see there, there are actually only relative contraindications that are, of course, conditions that are incompatible with normal life, pre-existing conditions, and then there is age and size of the patient. So the Extracorporeal Life Support Organization recognizes that probably advanced age and maybe the extremes of the BMI may be considered relative contraindications to ECMO support. There are also specific guidelines for veno-venous ECMO, and as you can see there, both age and weight are considered relative contraindications. For the age, they say that there are no specific indications, but of course the risk of death increases with increasing age. And for the BMI, it's considered that, well, actually they say the weight, that over 125 kilos can be considered a relative contraindication, especially because of difficulties in cannulation. And again, the same organization, and here we more or less the same principles. So we start talking about age. So there are many studies that have been published in the last 7-8 years that show that increasing age is associated with increased mortality of the patients. You can see this is a relatively small study, but that shows that there's actually a clear relationship with mortality with patients with the age of higher than 64 that die much more than the other patients. And this is the EOLIA trial. And you know that the EOLIA trial is the largest randomized controlled trial on ECMO that has been published in the New England Journal of Medicine by Alain Combe. And also in the EOLIA trial, even if there is no statistical significance, there is a trend that shows the increasing mortality with increasing age. This is the last and probably the largest observational study published so far. On 27,000 patients on VV ECMO, and the total hospital mortality was 40%. But again, you can see a clear relationship between age and mortality. And what is interesting is that the authors point out that increasing age is significantly associated with mortality, and that the association emerges as early as 30 years of age. So these are our Italian data. You may know that in Italy we have quite, I would say, large ECMO network. So it's not as large as in Germany, where there are hundreds of ECMO centers. In the UK, they have another completely different system, so very few centers. So they tend to centralize a large number of patients in very few centers. In Italy, also for geographical reasons and how the territory is done, we have decided to have a network of about 15, 17 centers that cover the entire nation. And so these are the data of the first 10 years of our Italian ECMO network. So from 2009, when we started, due to the H1N1 pandemic, up to 2019, so the first 10 years. So these are not, there are no COVID patients in here. You can see 1,300 patients, more or less. The mortality is in line with what is reported on the literature for severe ARDS, around 40%. And you can see, again, that this is the multivariate analysis, and the age is one of the factors with a stronger association with mortality. So every 5-year increments, you can see how much the mortality of the patient increases. And that's the last paper that I want to show you on age. It's been published by Tommaso Tonetti and Marco Ranieri. As you know, meta-analysis and meta-regressions we cannot stay without them now. So it's a meta-regression analysis of many studies that included at least 6 patients published in the last 10 years, 6 patients on ECMO. So they ended up analyzing 173 studies and more than 56,000 patients, non-COVID, and 100 studies and 21,000 patients, COVID patients. And they performed some sensitivity analysis in order to take into consideration the quality of the studies that reported only mean age and not the range of the patients, and also possible other associations between age and outcomes. And in the end, what they saw that there was a a significant association between hospital mortality and age in non-COVID patients, while in COVID patients, the association was again detected for ICU, but not for hospital mortality. But still, I mean, I think that all the data are more or less consistent. And of course, we have to take into account some limitations. Well, first of all, these data come mostly from observational studies. And in observational studies, they describe age, of course, as a number, but they don't take into account baseline conditions and frailty of the patients. In most of these studies, there is a non-ECMO cohort that can be compared. And most of these studies have, at best, hospital mortality as outcome, which is, of course, a hard outcome, but we all know that, especially for older patients, what is really relevant is probably the long-term survival and long-term sequelae of the critical illness. So we are now, I think, shifting our interest from mortality as the only outcome of interest to, more important outcomes like the quality of life after a certain point and long-term survival, because many of these patients, especially elderly patients, even if they survive the ICU and if they survive the hospital, maybe they die within 2-3 months after hospital discharge. And this is also something which is very important to take into account. So whenever we talk about mortality, we have to always keep in mind these limitations. Now, let's talk about BMI and patient size and weight. So this is, again, the EOLIA trial. So in the EOLIA trial, as you can see, one of the exclusion criteria was a weight higher than 1 kilogram per centimeter of height or a BMI above 45. So severely obese patients, morbidly obese patients were actually excluded by the EOLIA trial. And again, there are some observational studies, again, mostly retrospective, that try to study the association between body weight and mortality in ECMO. Some of them come from the registries, in particular from the ELSA registry. This is one of them that has been published 2 years ago. This is a retrospective analysis of 1,300 patients on VV ECMO in the ELSA registry, and the primary outcome was hospital mortality. And as you can see, there is no association between BMI, high BMI, and mortality. And here comes the new unexpected, probably, findings. This is a paper, for example, that shows that, again, a large number of patients, you can see there, thousands of patients, and you can see that there is a sort of counterintuitive relationship between BMI and mortality, with mortality decreasing with increasing BMI, or actually mortality increasing at the extremes of BMI. But you see there, so apparently obese patients survive more, on ECMO survive more. And we published this paper with Dan Brody and another group of international investigators. It's, again, a retrospective study, but it's many patients, so 790 patients on VV ECMO, and 300 of them had a BMI above 30, so what is now classified as obesity. And in the multivariable analysis, you can see that actually while increasing age was associated with mortality, higher BMI was associated with improved survival. Okay? But obese patients had lower Apache 2 score, lower PF ratio, and higher PEEP at cannulation. And these are the Kaplan-Meier curves from the same study, and that clearly show that obese patients, patients with BMI above 30 had a lower mortality. And I think that it's quite a clear association here. The same is for COVID patients. You know that many COVID patients were like patients with influenza, that many of them are obese. This puts together 17,000 patients from 42 studies. And of course, the studies selected different cutoffs for age and BMI. But this confirms what we know. Again, that older age is associated with mortality and higher BMI is associated with survival, improved survival, also in COVID patients. And if we want to look at VA ECMO, so veno-arterial ECMO for hemodynamic support, again, the data are quite consistent. This is the largest observational study, again, from the group of Dan Brody. 574 patients with cardiogenic shock supported with VA ECMO, and patients were subdivided according to two BMI classes, below or above 35. And again, obese patients were tended to be younger, and of course had higher rates of diabetes, but this is expected. But in this paper also, the only factor that was associated with mortality was very low BMI, but not the higher BMI. That's another meta-analysis on a certain number of studies, large number of patients, and you can see that the mean age of the patients was similar between obese and non-obese, and obesity had no impact on mortality, no impact on ECMO duration, no impact on mechanical ventilation duration, and no impact on length of hospital stay. So actually the authors conclude that the healthcare providers should be aware that there are challenges when you put an obese patient on ECMO, especially challenges related to cannulation, but that obesity per se should not be considered a contraindication to ECMO. Why is this? You know that there is this obesity paradox. It's been described very frequently in our patients, so that apparently obese patients survive more the critical illness. Well, there are several explanations. This is the editorial that Pickers wrote to our paper in the Blue Journal. So he pointed out that, well, first of all, most of the obese patients have a higher risk of atelectasis, so probably saying that maybe the respiratory failure is more reversible than expected, because probably if you put them on higher PEEP and higher pressures, then you may more easily reverse the respiratory failure. Then there is probably a selection bias. So the point is that we still consider obesity as a disease, as it is actually, but so probably we are more prone to consider as candidate for ECMO when the patients are obese, younger patients and patients with less comorbidity. So maybe we do a sort of selection. So, okay, we put obese patients on ECMO, but we tended to put the better patients on ECMO, okay, because they are probably younger, as it was seen in many studies. Then they might have a better nutritional reserve, and then other possible explanation related to biology and to the influence on the immune system. It's also interesting to see that in both these scores, so these are two scores that are used to predict mortality of ECMO patients. Some people also advocate their use to select the patients when you have to decide whether you want to put a patient on ECMO or not. I'm a bit skeptical, of course, because these scores have been calculated post-hoc, I mean, in patients that have already been put on ECMO, so I wouldn't decide whether I have to put a patient on ECMO based on the score, at least outside very special situation like pandemics, or I mean, when you need to do a triage of the patients, I think that the indication to ECMO is always a case-by-case discussion and should be really personalized. But anyway, you can see that in both these scores, like the PRESERVE score and the RESP score, they do not consider obesity as a risk factor for mortality, or actually they consider obesity as a protective factor for mortality. So these are my conclusions. Well, we have seen that age, increasing age, has a linear relationship with mortality in patients on VV ECMO, but it's the same for VA ECMO. I cannot give you a threshold of age, and we are actually moving higher and higher this threshold in our clinical practice. So when I started, I think that putting on ECMO a patient above 65 of age was, I don't know, very, very rare. Now we tend to take to make more general consideration of not only of the biological age of the patient, but of course of comorbidities and frailty and pre-existing life conditions. So age is certainly important. So you know that the higher the age of the patient, the higher will be the probability of death of this patient. But this is not only for ECMO, of course. I think it's for every critical illness. But again, if you want to decide to start a very invasive procedure like ECMO in an older patient, then you need to take into account not only the number of age, but his pre-existing condition and frailty. Obesity and high BMI should not consider a contraindication to ECMO, even though some of the larger studies, as you have seen, used morbid obesity as a contraindication, like the EOLIA trial. So this may, again, introduce a bias in the interpretation of the results, but at least in the large registry studies and in the very large case series, we have seen a sort of protective effect of obesity. And so obesity should not be a reason for denying ECMO treatment to any patient. Again, we know that treating these patients can be challenging for cannulation, for mobilization, but we have put on ECMO patients of above 300 kilos, and we've been able to tracheostomize them, to prone them while on ECMO. So it's feasible. Of course, you need to select a good cannulation strategy. You know that you will have some problems related to the patient size. But these should not consider per se a reason to deny ECMO treatment to a patient. Thank you very much for your attention.
Thank you so much for all the speakers. I think we learned really a lot because of you and because of all these nice talks. So now the discussion is open, and the speakers are here to hear from you, to have your questions, your interrogations. Just one indication is that, please, but can you come just closer to the stage, because we have big problems of sound and sometimes we don't really hear clearly the question.